Good evening, ladies and gentlemen. I hope you can hear me.
Yes, please.
All right. It appears attendance is the least. They are having the lowest attendance today, but life must go on. So we're going to start. I hope you are all doing well.
By God.
So we're going to have in-depth discussion on syphilis serology. I started by saying that when it comes to our topic, we wouldn't have wasted much time on syphilis, because ours is to just mention that syphilis, the primary stage of syphilis, is one of the diseases that can affect the penis, because the general topic was genital ulcer diseases, GUDs. And here you're talking about ulcers or sores, which can appear on the genital area. And since our focus also on the penis, then it is that ropes in the element of syphilis. And with syphilis, it's multi-stage. Stage 1, stage 2, stage 3, stage 4. And it's only the stage 1 that will have some manifestations on the penis in the form of the chancre or the sore. Right. So otherwise, we'll just have mentioned that and go away. But I know that a lot of us have challenges with proper diagnosis and interpretation of serological reports. And so I think that we should have some time with. So that becomes like a bonus for you as far as this course is concerned. All right. So we started by saying that the primary stage of the syphilis manifests with the typical hard sores, which we call a chancre. And whether you treat it or not, it will simultaneously or it will spontaneously go away in a matter of 2 or 3 weeks. All right. But once it goes away, whether you treat it or not, that doesn't mean that the infection is over. So without treatment, the infection will move into another stage, which we call the secondary stage. We said that in the primary stage, sometimes it becomes difficult to diagnose as lab scientists because we have some limitations. The fact is that you may see the wound or the sore or the ulcer. You may take a wound swab, but if it is due to syphilis, it cannot be cultured in the lab. So you realize that even if you want to gram, the gram may show some secondary contaminations. You can see some gram-positive cocci and stuff like that, but they are not a causative agent. The causative agent itself, which are triponyms, cannot pick the gram stains, and therefore gram is irrelevant. You do the gram stain, you don't see anything. And then we said that even if the gram should pick it up, at the end of the day, you are going to examine under the microscope, the light microscope. And we said that the organism is so slender. If you look at the dimension, the length is all right, about 5 to 20 microns, but the diameter is just about 0.1 to 0.4. Most of them are below the microscopic levels that can be observed. So we say it is submicroscopic. So it means that you cannot gram stain it. You cannot examine it under the standard microscope, and you cannot culture it. And so therefore it becomes almost impossible for diagnosis. So your best bet is the serological analysis. All right, taking a sample, blood sample, and trying to make a diagnosis out of it. But you also know that that has a lot of limitations, because the primary stage, before any for an infection to induce antibodies, you realize that there's always what people call the window period. All right, that's the time span for which the body will now try to produce antibodies. That case, it means that if you want to rely on serology, that one to fail. So syphilis diagnosis is a challenge. It's a challenge for the lab. All right, and we said that with the primary phase, you may see the ulcer. The ulcer will be very classical, or everything about it is classically diagnostic for syphilis. Yet, we are dealing with evidence-based. Yes, it's like somebody comes with malaria, everything points to the fact that he has malaria. But you can't, based on that, and give the patient malaria treatment. There must be an evidence that to be supported by the lab. You should do your malaria slide and then actually confirm that the patient has malaria parasites. So you can see the source and everything, which could probably give you a strong indication that it is syphilis, but there must be a laboratory support. And at that time, your best bet is to take a swab and try to do the dark field microscopy. However, how many labs in Ghana have routine use for dark field microscopes? I don't know even if some teaching hospitals have dark field microscopes. So what it means that even where the sore is classical and you need a laboratory diagnosis, do you have dark field microscopes? You don't. And so that also becomes a challenge. And therefore, you must have a good understanding of the serology. Okay, how all aspects of the serological diagnostic component that will be able to support you and also the clinician. All right. So we started by saying that following infection, that is, once we have been exposed to the bacteria, the body of necessarily will develop antibodies, which become detectable in 3 to 4 weeks after the exposure. All right. Remember that we said that apart from, or let me put it this way, all we know is that antibody productions are so specific, and they are specific against the antigen that induced their production. But when it comes to syphilis, that it's a different ball game. All right. When it comes to syphilis, they are rather producing 2 types of antibodies. And for the 2 types of the antibodies, one is very specific against the trichoderma antigens. Another one too is non-specific. What it means is that, like we know, if you have antigen A, the antibodies that are produced must be specifically against the antigen A, which causes its production. But when it comes to syphilis, especially the non-specific or non-trichoderma antibodies, the antibodies that are produced are able to actually engage, and for that matter, react with substances like cardiolipin, lecithin, cholesterol. These are like lipid components that are coming from the organism, the troponins. But you see that lecithin, cardiolipin, and then the cholesterol, they are also common things that can come from the host cell. You remember when we're dealing with the post-ejaculatory urine, in the case of retrograde ejaculation, we said that we could depend on fructose analysis of the urine. But once it comes to a point that, okay, if you're using fructose does not necessarily come from the semen alone. If the patient is already having a challenge and is having fructose in the urine, how will we be able to differentiate the fructose coming from the patient himself and then the fructose coming from the semen? So that becomes a diagnostic error. So similarly, you have a situation where cholesterol, lecithin, and then cardiolipin, they are all components of the cell walls for that matter, the membranes of the T. pallidum. However, the same substances can also come from the host cell, especially when the patient has been exposed to T. pallidum. A lot of cells are damaged. And out of the damaged cells, you also have lecithin, you also have cholesterol, you also have cardiolipin. And so how are you going to differentiate between the ones that is coming from the host cell and the ones that are coming from the organism? So that also creates a challenge there. So it means that now these antibodies, which are supposed to be specific, are not specific. And therefore they lose a key characteristics of an antibody. So therefore some scientists said that no, then this thing you are calling antigen, sorry, this thing you are calling antibody is not an antibody. So they coined the term reagent. So the term reagent is just a terminology that was coined to represent the kind of so-called antibodies in quotes that are produced by syphilis. All right. So I said that is one component. But there is also another component of the antibodies that are actually directed against the T. pallidum. And so you have those two classes of antibodies. And you have to know how to use the two of them in a way to make proper diagnosis of syphilis infection. Right. I'm getting some feedbacks. Who is talking? If you want to ask a question, please do. I'm Buffy. If you have a question to ask, please do. Otherwise, you mute. I'm Buffy. Are you on your phone? Are you sure you're on your phone? I am Buffy. Will you ask a question or mute? Okay. So let's move on. So we said that we have the non-treponema and then the treponema. Let's have a good understanding of the treponema antibodies. Right. So the non-treponema, which is also the non-specific, and the word non-specific is saying the fact that that defeats the description for an antibody, because antibody should be specific. And so if you have an antibody that is also reacting with all kinds of things, then that makes it non-specific. It is also non-treponema because other things other than the treponemes, and as you move along, you see all those things that they are also non-treponema. For example, if you have malaria, you could have a reaction, you have the test showing positive and so forth and so on. So those things become non-treponema. All right. So that is, you can use the non-treponema and non-specific interchangeably. All right. The same way as you move along, you see that they also call anti-lipoidal antibodies. Why are they called anti-lipoidal antibodies? You see, antibodies are usually against an antigen. Now, we said that the substances which are actually attacked or which are actually of target with respect to non-treponema antibodies, who can mention them for me? What are the substances that are of target under the non-treponema? Which are the substances? The substances of target. Yes, I'm Buffy. You are talking. So answer this question. What substances are targeted in the non-treponema antibodies? Anybody can help? The substances of target in the non-treponema antibodies. I think I've mentioned them several times.
Lipid molecules, some lipid molecules.
Specifically, what are they? I mentioned them several. I said cardiolipin, lecithin, and cholesterol. These are the substance of, but they all have some lipid component in them. So remember we said that in medical terminology, the word OID means like. Okay, OID means like. So when you say lipoid, so it's like a lipid and OID. So that is lipoid. So what it means is that these substances, also these antibodies, are able to react with the lipid-like substances, which are lipoid. So, and antibodies are going to react with antigens. Is that not it? So then the cardiolipin and then the lecithin and cholesterol, since they are all lipids, we can call them lipoidal antigens. So if you read elsewhere and you see lipoidal antigens, this is where it is coming from. All right. And so the non-trichodermal antibodies are also referred to as anti-lipoidal, because any antibody that can react with an antigen is supposed to be anti. So if you have antigen A and you have antibodies reacting with antigen A, you can say that antibody is anti or anti-antigen A. So what I'm saying is that if you come across anti-lipoidal, what it means is that the non-trichodermal antibodies are able to react with cardiolipin, lecithin, and cholesterol, all of which are lipids or like lipids. And they are also called lipoidal antigens. So the antibodies which are coming to attack them can be said to be anti-lipoidal. The dominant one is cardiolipin, even though lecithin and then the lecithin and what do you call it? Even though lecithin and cholesterol are all there, but the greatest component is cardiolipin. And therefore, non-trichodermal antibodies are also sometimes called anti-cardiolipin. So take note of all these things. Today, we're going to deal with a lot of technologies. And that is to open up your mind to go beyond what the ordinary lab scientists know. Okay. And that will also indicate the fact that you have an advanced knowledge in, let's say, syphilis determination or syphilis diagnosis. So the lipoidal is talking about the group of substances which can be attacked, and for that matter, reacted by the non-trichodermal antibodies. So they are lipoidal antigens, and they are classically cardiolipin, lecithin, and cholesterol. And they are like lipids. So you say they are lipoidal, like lipids, so lipoidal. And excuse me, somebody is consistently calling me. Let me just respond in a minute. Sorry. So I'm back. I'm just saying that there are a lot of technicalities and terminologies associated with syphilis, and I'm taking my time to explain them so that you understand them once and for all. If you hear about anti-cardiolipin antibodies, they are the same thing as the non-trichodermal antibodies. Because here, the non-trichodermal, we're saying that the antibodies that they attack are cardiolipin, lecithin, and then the cholesterol. These are all like lipids. And so once they are like lipids, we say they are lipoidal, lipid, and then OID, lipoidal. Okay, so they are also called lipoidal antigens. Therefore, the antibodies which are reacting with the lipoidal antigens can also be called anti-lipoidal antibodies. And I'm also saying again that of the three, the dominant one is cardiolipin. And so therefore, sometimes the non-treponemal antibodies is also called anti or anti-cardiolipin antibodies. And so once you understand all these concepts, whichever way anybody talks about it, you appreciate it. Okay, right. Now, so these are found in active disease and the levels subside after successful treatment. All right. While treponemal specific antibodies persist for life even after the infection has been successfully treated. So as we move along, you see that we have said that we have two antibodies, a non-treponemal and a treponemal. One will go away after the patient has been successfully treated. Okay. Another one will also persist throughout life. As we move along, we also see which one even comes first. Okay. And all these things should guide you in your diagnosis. So the serological tests most commonly used to screen syphilis are the non-treponemal tests such as VDRL and RPR. I'm sure VDRL is very, you all know about it, venereal disease research laboratory. And the RPR is rapid plasma reagent. And I've told that reagent is talking about the fact that the non-treponemal antibodies, people think, or some scientists think that it is not antibodies. And therefore they have to give it another terminology. And they say it's a reagent. The emphasis is that if they were antibodies, they will not be reacting with so many things. Since they are reacting with so many things, then they don't qualify to be classified as antibodies. So that's their point. Rapid, you will see that it is in comparison with VDRL. VDRL was the original test which was designed to test for syphilis. Let me also put here, or let me also mention that even before VDRL, there was a test called CAN test, KHAN, CAN test. There's a test called Wasserman test, Wasserman test. These were all OO tests which were developed for diagnosis of syphilis. So, especially with the CAN, some OO doctors still write for CAN test. They may say write for CAN test. If any doctor writes for CAN test, KHAN, is talking about VDRL. All right, so take note on that. So the VDRL and the Wasserman test, and then the Wasserman, CAN test, VDRL, they were all O tests. Now, but especially with the VDRL, in comparison with the RPR, as you move along, you see that they are the same, virtually the same. But the RPR is a modification of the VDRL. And the VDRL will take time. I mean, when it comes to rapidity of the testing, VDRL will take time. For example, even with the VDRL, you have to heat inactivate the serum. What do you mean by heat inactivation? Who can tell us when I say you should heat inactivate a serum or serum inactivated? What does it mean? Please, you say something. If you are all learning, if you don't know, that's why we are here. We are learning. What is heat inactivation of serum? Please say something, please. We are learning. And you are so lucky because this topic on syphilis is another course on its own. Okay. It's another course on its own, and you are having it virtually free. All right. So let's move on. So the heat inactivation, what it means is that serum, you put serum at 56 degrees. If you put serum at 56 degrees for about 30 minutes, all the complements will go off. And as you move along, you appreciate why for VDRL, the serum, first and foremost, you have to use serum. Because if you don't use serum, you use plasma. VDRL originally, if you use plasma, remember what's the difference between plasma and serum? This one there, if you don't know, you won't go away. We won't move forward. The difference between plasma and serum. If you don't tell me, we will close today. That this will be unacceptable. Difference between serum and plasma. Yes, sir. Moses.
Serum, serum is derived from clotted sample, and plasma is derived from unclotted sample.
Okay. All right. I'll take that one. So you see that with the plasma, you have all the clotting factors there. Is that not it? In the plasma, you have all the clotting factors there. So you realize that here you are talking about a situation where non-terpenomer antibodies react with a lot of things. Okay. So to make it more even worse, what it means is that if you are using a plasma contains all the clotting factors and all the complements, everything is already in there. And so they're also going to add on to the things that can also react with the non-terpenomer antibodies and make the test less sensitive. Okay, so to minimize that, to minimize the interferences, when you use serum, you are taking away all the clotting factors. Is that not it? Because it's from clotted blood. So you are taking away all the clotting factors. So it means that you are reducing the chances of interferences with the non-terpenomer antibody because those antibodies themselves are non-specific. And so they react with a lot of things. So once you use serum, then it means that you are reducing the chances of interferences. And even that, once you take away this, once it is serum, the complements are still not destroyed. The serum only took away the clotting factors, but complements are all there. And all complements too are also potential interferences. So what you do is that in the VDRL, you are going to put your serum, I say you can't use plasma. So you're going to use serum, and even the serum, you have to inactivate it. What it means is that you put at 56 degrees for about 30 minutes. Once that happens, it's going to destroy all the complements. This is a way to minimize interferences. Okay, and you see that the inactivation process and all sort of things will extend the testing time, your turnaround time. Okay, so once RPR was developed, RPR is saying that rapid means now the test is going to be, the R is rapid. Here you are not going to use serum for the RPR. You are not going to use serum. You can use plasma. So in plasma, or you take the sample into an anticoagulant, either UDT or straight, and then you spin. For the VDR, you have to allow the blood to clot, and that alone can take some 30 minutes for the blood to clot before you now go into the inactivation stage. So that alone is taking a lot of time. Now, since you are going to use plasma in the case where the blood sample is collected, put into an anticoagulant, either heparin or citrate or EDTA, you just spin immediately. And once you use immediately, and you are not going to inactivate. All right. So that process makes the testing rapid. Okay. And the fact that we are using plasma too is indicated in there. So RP, and then R is reagent. The reagent is talking about the fact that you are going to test so-called antibodies which are not typical antibodies, and they have been coined as reagent, not reagent. So that's the history behind RPR. So RPR is rapid plasma reagent, and this in comparison with VDR. When we get there, you see that RPR and VDR have the same principle. They have the same reagent, and as to how this becomes rapid, you get it from that point. But I'm saying here that RPR is a modification of VDRL, and VDRL is a lot of challenges with the VDRL testing. All right, so the RPR VDRL, they measure the non-terpenomer antibodies. Okay, all right, and we said that they respond to antigens such as cardiolipin, lecithin, and cholesterol. And remember, I've said that these substances are also released from damaged host cells. Okay, and they're also coming from the organism itself. So that's where the controversy arises. So on the non-terpenomer, and for that matter, non-specific tests typically have been used as the primary screening test for syphilis. Okay, So primarily, you use the non-treponemal test. So they are for screening. Okay. They can be used as diagnostic tests when the patient have signs and symptoms. So if you what do you call it? If you are using the VDRL or RPR alone, it can only be used as a screening test. However, if you use it as a screening test and the patient has classical, let's say, chancres, and they tell you that, oh, I've had a sexual contact with my partner, and my partner has already been diagnosed with syphilis, then straight away you don't even need to do any confirmation. So the non-treponemal test itself has now become diagnostic. All right. Okay. And also when assessing possible reinfection, because we said that as we move along, it becomes very clear that of the two types of antibodies, the non-treponemal one, once they appear after treatment, they can go away. So if at that time it is becoming positive, then you know that there's a reinfection. Okay. Okay. And then also for monitoring treatment, you talk about all those things in subsequent slides. How do you monitor treatment? And also it's based on the fact that once the patient is treated, then the titers, and you will explain all those in titers, that's the level of concentration. The concentration, yes, you understand concentration. The concentration of the antibodies will also begin to go down. So once it goes down to a certain point, you will know that then the patient has been successfully treated. But there are a lot of terminologies there which we will talk about. So, so it means that the non-treponemal test is not just for screening, but can also be used for monitoring treatment outcome. All right. So the non-treponemal tests are generally sensitive in early syphilis, but lack sensitivity in the late stages of the infection. We will explain this as we move along. Right. We didn't go beyond the secondary stage, but you know that there's the latent stage and then the, what do you call it? The tertiary stage. What we said in passing was that in the tertiary stage, they are not contagious. And we said that they are not contagious because a lot of them are in deprived, whether that word is correct, in very deprived, or there's a terminology they are forgotten, but they are in places that are virtually hard to reach. For example, once they are in the CNS, how are you going to get contact with them? When they are in the bones, when they are attacking the heart, for example, how are you going to get heart? So, because at that stage they are infecting internal organs. Okay, right. So that makes the late stage syphilis diagnosis also another thing altogether. But once we also, as we move along, you see that we are dependent on the antibodies. From the primary stage, the antibodies are not too much. As we move to the second stage, antibodies are coming, and to the latent phase, the antibodies have been so much so that there are even more antibodies than the organism themselves. Okay. Now, when we come to diagnosis, we are using the antibodies. And as we move along, we are going to talk about proteasome effect, where in the presence of overwhelming amount of antibodies, reactions become negative. I don't know whether you understand what I'm saying. In the proteasome effect, the antibodies overwhelm the antigens. Antigens are the reagent that we are going to use, because in an antigen-antibody reaction, you look at where is my antibody coming from. My antibody is supposed to be coming from the suspected patient sample. So I have a patient I'm suspecting to have syphilis. And so therefore, when I take the patient's sample, I'm expecting that the patient's sample should contain antibodies. So that's my source of antibodies. Where is my source of antigens? My source of antigens is the reagent that I'm going to provide. And these are the lecithin, cardiolipin, cholesterol complex, which have been prepared as a reagent. Okay. Now, so if the patient that I'm dealing with is in the latent phase, the latent phase, it's been known that the patient doesn't even have symptoms. The patient had been overwhelmed by antibodies. So the small amount of sample that you take has large concentration of antibodies. Meanwhile, with your antigen, the test that you're going to do, if you are taking one drop, you're taking one drop. And that is so you have a standard amount of antigens that you are providing. Meanwhile, the antibodies that you are going to add from the sample is so much. So what it means is that you are going to have a disproportionate amount of antibodies and antigens. As we move along, you're going to look at the aspects of optimal concentrations, that to have an effective antigen-antibody interaction, there should be that kind of optimal concentration, which we call the zone of equivalence. So there should be equivalent number of antigens and antibodies, and that is going to give you an effective antigen-antibody interaction. Okay, if one overwhelms the other, it makes the interaction defective. This is what I'm talking about. So with the non-treponema, that plays role. It plays it plays a big role in there, where the overwhelming amount of antibodies makes the reaction in the long run to become virtually negative. All right. So, and that now falls into the disadvantages or drawbacks of the non-treponema test. Please, if I'm going too fast, or if you don't understand anything, please hold me back, because these things are very, very, very important. And as scientists, we must know this. And unfortunately, we are not taught these things in school. Okay. Or if they are teaching at all, they'll just mention it in passing. But you are practitioners, and also students will come to you, to your facility, to also be trained. So you must have knowledge over and above the ordinary person to be able to actually handle those cases. So now we're talking about the drawbacks or disadvantages of the non-treponema test. Now, first, we're talking about false positive reactions. We mentioned that apart from the fact that the antibodies which have been induced by the fact that you have been exposed to the syphilis, the antibodies that the body produces, is already also reacting with certain antibodies which the body themselves produce. And we said that they are from damaged host cells, because once the infection comes in, some cells are damaged. And you see that within the internal systems of the cells that are damaged, there are a lot of lipids, including the cardiolipin, especially if the cells damage are coming from the heart. So that's why you have cardiolipin. That's the heart associated, okay, lipids. So you see that there is an increased amount of antibodies that will also react with cardiolipin and so forth and so on. So that aspect is there. And then again, we said that even apart from the fact that they are reacting with the host cells, they're also reacting with certain things that are not related to the disease at all. Like even if you have malaria, even in ordinary pregnancy, the fact that the person is pregnant can give you a false positive. These are called BFPs, biological false positives. Biological false positive. The patient may have, let's say, viral pneumonia, or even tuberculosis, or any of those things. The patient's serum will react and give you a positive for syphilis. So if you don't know all these things, then you also add up to the misdiagnosis and then also the mistreatment that are given to patients. So once you have a very good understanding of the syphilis serology, you'll be able to now also interrogate and say, no, this positive thing, the patient already has malaria. So let's finish with the treatment on the malaria, and then later on you can come and do the syphilis. Otherwise, the syphilis may give you a false positive. That is the way to go as scientists. All right. And then we also talk about a false negative reaction due to the prozone phenomenon. And I mentioned that the prozone is, remember we said that the zone, or I mentioned that there's something called zone of equivalence. That if you have antigen and antibodies and you want them to react to give you the optimal agglutination, and you have slides on all those things to come then. If you want to have the match anticipated or the highest amount of agglutination, then there should be that kind of proportionality of the antigens and the antibodies. Okay, so that's what we call the equivalence. Now, if you have too much of the antibodies against the antigens, it's like I mentioned before, there's going to be, it's like if you have in a class, there are a few girls, that too many boys, and everybody wants some of the girls. You will see that you'll be fighting over them, and before you could say Jack, nobody even get the girl in the first place. All right. But if you have the girls are 50-50, I mean, that one, okay, unless you have some greedy guys who may take 3, and then while somebody will also not get some. Otherwise, you see that everybody will guess his or a partner, and then you are free to go. But if you have 2 girls and then 48 guys, you see that there's always going to be confusion. At the end of the day, nobody even gets the guess. All right. So that's what, if you have too many antibodies, there's that kind of interferences. And at the end of the day, there's no even reaction. That's what we call prozone phenomena. Okay. And you see that even though the antibodies are there, but the test show that it's negative. Okay. As we move along, I'll explain further on all these things and also demonstrate how to, in the lab, how to deal with such a situation. Okay. All right. And then lack of sensitivity in the late stage of infection. I've mentioned this already. Okay. Now, so that is a little information or more information about the non-treponema ones. All right. Now let's get a little information about the treponema test. And of course, treponema test will also detect treponema antibodies. So the treponema test targets specific T pallidium antigens. So these ones are more specific. So the treponema tests are also called specific treponema antibodies. Okay, because they target or specifically react with T pallidium antigens, and are used to confirm results of reactive non-treponema tests. I hope you are not confused, right? When you have done a non-treponema one, which is non-specific, they use a treponema test to confirm, because treponema ones are more specific. Okay. Now, take note of this, which are bolded. The treponema antibodies become positive earlier after acute infection than the non-treponema ones. What it means, one thing about acute infection, that is immediately after exposure to the infection. Okay. Once you've been exposed to the infection, which remember we said we have the non-treponema antibodies and treponema antibodies. Which one comes first? And here, this is telling you that the treponema antibodies show positive first. They show positive first than the non-treponema one. So as you move along, you realize that, I mentioned the other time that treponema ones are specific, and the rapid test kit that we're using, that's why some people think that that's the way to go, because they belong to the treponema group. The test strip that we are using, they belong to the treponema antibodies group. Once they are specific for treponema antibodies, what it means is that they're able to detect the infection first. So once they detect the infection first, because the antibodies come earlier, if you were to use the RPR or something, it will show negative. Then somebody will tell you that, oh, look, the strip is even far better than the. If you don't know the science behind the syphilis serology. That's what we're going to say. Oh, because this one detected it, this one did not detect it. So it means that the VDR is wrong. It's not wrong, except that the VDR, which detects the non-troponin ones, they are, and as we move along, we're going to talk about seroconversions. The rate at which antibodies are produced are faster with the troponin one than the non-troponin one. Okay, and therefore it makes it easier for you to know that the troponin antibodies or the troponin test kits will be positive while the non-troponin will be negative. Okay, so therefore, troponin tests can be used to evaluate patients with signs suggestive of syphilis in early primary infection. What it means is that you already have the patient having signs of an infection. Okay, once you have signs of infection, you may not even have to do the VDRL. Okay, you may not even have, even if you have it, you may not have to do it. Then the rapid test case will do better because that one will give you an earlier infection. The rate of production of the antibodies is faster in there, and therefore you can easily pick it up and then say that the patient is confirmed to have syphilis. All right. I've said this. We want to repeat that troponin antibodies persist for life, not for some time. The troponin antibodies typically persist for life despite treatment. So that remember that with the non-troponin antibodies, after treatment, the antibodies will go down. And we are going to look at all the terminologies associated with this. However, with the troponin antibodies, they will persist throughout the person's life once the person has been exposed. And whether the patient, even after successful treatment, the patient will still be will have a positive outcome up to the end of life. Okay, so these are critical information that as scientists we should know. All right. Okay, so then serodiagnosis. That's using the serum, the serological test for diagnosing syphilis. So we have known all those things. All right. And so this is just a recap of all that we talked about. Yes, I won't talk again here because I've said the same thing, that non-troponin test and then troponin test. I've said it all. Now let's look at serodiagnosis, some terminologies. And take note here. A lot of terminologies that are associated with syphilis diagnosis or serodiagnosis. Serodiagnosis is using serum to diagnose syphilis. All right. Now, what is seroconversion? Remember, we said that once you have been exposed to an infection, the body will have to do the production of the antibodies. And all of us know basic science, we know about the window period. It is this so-called window period, which in syphilis serology is called seroconversion. Because initially, if anybody tested you for syphilis, you will be tested negative. All right. Now, so we say, what is your sero status? Even if you want to check about your HIV status. So sero status means what is the status of your serum? Take note of some of these things. When you say, what is your sero status? What is the status of your serum? That is, if they took your serum and tested it for HIV, what will be your status? All right. So if you don't know your sero status, they say no. But if you know that you are negative, you can say that I'm seronegative. So that's seronegativity. If you test your serum and then you become positive, that is seropositivity. But otherwise, the status is sero status. The same thing applies here with the syphilis. So once you have not been exposed to the infection, you are seronegative. Now, once you have been exposed, then the body will now build antibodies against the syphilis. And so you are converting from negative state to a positive state. So that's seroconversion. So seroconversion is just the movement from a positive, sorry, an otherwise negative state to a seropositive state. And it will take time. And that is what I've said over and over again, people call the window period. So the time period for which specific antibodies against specific antigens are produced, as simple as that. That's it. And it can happen even in immunization. So once you have been immunized, you won't get antibodies straight away. Okay, it will take time for antibodies. So the period that it takes for you to get the required antibodies is the seroconversion state. All right. So the seroconversion is normally will move you from seronegativity to seropositivity. All right. So in syphilis infection, seroconversion usually occurs around 3 weeks. In syphilis, seroconversion occurs around 3 weeks because we said that that's the time period that it takes for the serum to show positive if you have to do the test. And remember, we said that in the seroconversion, the treponema antibodies, the specific ones, will come first before the non-treponema ones. So if you are saying that between 3 weeks and up to 6 weeks, it means that for 3 weeks, it is the treponema antibody that will have appeared. The non-treponema antibodies will appear later. But since we are dealing with the antibodies as a whole, that's where they're giving you this gap. All right. So consequently, patients can present with primary syphilis and initially have negative serologic tests. So this explains why a patient can have syphilis, all the signs are showing that he has syphilis, yet you do the test and it's negative because he has not seroconverted. All right. Let's look at what is also called seroreversion. I think the seroreversion will be opposite of seroconversion. Seroconversion, you are saying that you were originally negative. You have been exposed to the infection. Okay. Once you have been exposed to the infection and then you have been treated, after time, you should become also negative again. So that's seroreversion. You have reverted back to your original position. And the important thing here is that it is not a straightforward thing. It's not like once treatment is over, the next week you should go and test and then you become negative. No, it doesn't happen that way. As far as syphilis is concerned, it takes up to about 12 months. So also take note, the fact that we said that what do you call it? After treatment, the antibodies can test negative, doesn't mean that it's immediate. No, it can take up to 12 months. So take note of that. However, there's what we call a serological cure, which I'll mention in the next slide. In the serological cure, we are talking about a situation where, you did a test, it was positive, and you did what we call a titer, that's estimating the concentration, level of concentration. If your titer is, let's say, let's say 256, okay, and then after, let's say 3 months, you go and test, it is then your titer has come to, let's say, let's say 64. It means that has reduced drastically. And therefore, based on that, even though you are still positive, but the titer has reduced what we call fourfold. And I'll explain all those things when it comes there. Then it means that, yes, serologically, it can be said that the treatment has been successful. Because if the treatment were not successful, the antibody titer will not come that low. Okay. So, but reversion is talking about going back to where you were coming from. Before you got the infection, were you positive or negative? Before you got the infection, what was your sero status? If you follow the discussion, answer this question. Before you got the infection, what was your sero status?
You were seronegative.
Eh?
Negative.
So seronegative. So if you say you are reversing, you are going back to where you came from, it means that after the infection, seroreversion says that go back to where you were coming from. So you were negative, you became positive. And after the infection, even if it's 1 year, you have to go back to where you are coming from. So that's typical seroreversion. Okay. Now, and I've said that it takes time for seroreversion to take place. It takes time for seroreversion to take place, sometimes up to 1 year. All right. Now let's move to other terminologies. Serological cure. Seroreversion says that your after 6 months or after let's say 1 year, you should become seronegative. Okay. Serological cure is talking about the fact that there should be a significant decrease in the non-terminal antibodies. So if your antibodies was, let's say, like the example I gave, if you have 1 in, let's say, 64, 1 in 64, then if you have about 4-fold decrease, and when you say 4-fold decrease, as I'll take you through serial dilutions, and then you appreciate all those things. So if you have 64, 1 in 64, and then you are coming down, all right, you come down to 32, okay, and then the next the next level, 60 from 64, you come down to 32. The next level, you come down to 16. So even though just 2 steps from 64, you came to 32, and you came to 16. These 2 steps is so-called 4-fold, because 16 and then the 64, if you multiply, it's about 4 times. Okay, so that is what we talk about 4-fold. I explain it better when we are dealing with titers and then serial dilutions and so forth and so on. I've told you that this is a bonus topic. It has nothing to do with the andrology, and I feel that I need to deal with it the extent that you benefit from it. Okay, right. So that's the difference between seroreversion and then serological cure. Serological cure, you don't necessarily have to be seroreversion. Seroreversion expects that you should show negative because you were previously negative. So you are reversing back. So you should show negative. But serological cure is not saying that you don't necessarily have to be negative, but there should be a significant reduction in the titer. So once there's a significant reduction in the titer, about 4-fold, it shows that you are serologically cured. But of course, it can go on to become seronegative, okay? And that's a complete loss of antibody detectability. It means that the antibodies cannot be detected at all, and therefore you're also seronegative. I'm saying this again, seroreversion or seronegativity, once it comes to serological cure, it doesn't necessarily have to be seronegative. Anything which is in the range of a decline of 4-fold could be considered as serological cure. However, if it gets to 0 or negative, hallelujah. Okay, I hope that you are not confused. If there's any confusion in that between serological cure and then seronegativity or seroreversion, let me know. Seronegativity or seroreversion says that you were originally negative for syphilis. You were exposed and have become positive. After treatment, go back to your status. So that's seroreversion. Good. Serological cure is saying that, well, if you were negative and then you became positive, your titer was, let's say, in the range of 64. After 6 months or so, the titer has reduced to, let's say, just about 4. It hasn't become 0, but you qualify to be in the status of serological cure. If it comes to 0, hallelujah. But if it doesn't come to 0, but it comes to a significantly declined level, it is serological cure. And I'm hoping and believing that somebody has heard me. There is serofast. If you do, hello.
So all this is basically specific to the non-treponema because you said the treponema, that one it doesn't go.
Yes, please. Yes, please. Because the treponema one is permanent. Once you have it and develop, so you can't even do data on that. All right. So that's why by the end of the day, you realize that we are doing a big disservice to ourselves and to our clients once we are using the syphilis strips. The syphilis strips are based on EIs, which is enzyme amino acids, and chemiluminescent amino acids, and so forth and so on, which are all specific. Once they are specific, what it means is that once the patient has tested positive throughout the life, it will show positive. And that one, so we don't worry ourselves to do any titer or anything about it. All right, good. Now let me ask you this question. If you do a Zetan stain, how do you report it? I'm sure all of you have idea about the Zetan stain, the Zetan stain for AFBs, for tuberculosis.
Acid fast.
Acid fast bacteria. What does the acid fast bacteria mean? AFB, what does it mean?
We used to stain the acid fast bacteria.
Come again.
A staining technique that we use to stain the acid fast bacteria, commonly the TB, tuberculosis.
Yeah. I'm saying, why is it called acid fast? The word fast, you know, the fast, you are talking about the fast here. So if you have an idea about the fast, it will help us to understand the zero fast concept better. Okay, so
Papa,
yes, sir.
the acid fast, the fast as in those that I mean, if you have the bacilli present, it's hold on to the primary stain. That's the
fantastic. It holds on to the
primary stain. That's
yes. So holding on hard or fast. The acid fast, once you stain, it takes the primary stain, which is the carbofixin. Now you know that acid is a strong decolorizer. They will to tell you that having taken up the primary stain, whether you use acid or not, I mean, it will still hold on to the primary stain that has taken. Okay, so nothing will change. So that's the concept of the fast in the AFB, acid fast, holding on to it. So we said that once you have syphilis and you have been treated, after some time, I mean, we are talking about the treponema test. Sorry, non-treponema test. We said that the treponema test doesn't. I mean, that one there to be there, but we are using the non-treponema test because that one, once you have been treated with time, it has to go away. There are some people, for whatever reason, the level will not come down, even though they have been treated. Everything can show that they have been treated, yet the antibodies levels will either come down very small and doesn't come down again, or it will not even come down at all. Whichever level that you got, anytime you check it, it can still be positive. These are things lab scientists should know. I'm telling you, because if you don't know, it's like the VIDA test that people do. People don't, and that's the concept of the zero fast. Some people, they get a titer and it will never come down. Anytime that you do the VIDA test, it will still show high. Meanwhile, it doesn't have any clinical manifestation of typhoid. Yet, there are certain people whose serum, once they build up antibodies to a certain level, it never comes down. This is serofast individuals, and scientists should know, so that you don't unnecessarily expose people to avoidable medications. So please, I'm saying that all along up to this point, you say that once you get syphilis and then you have been treated, then antibodies that non-treponema antibodies will have to come down, which is fantastic. it may come down to a certain point about four times level, which is the serological cure. That one you understand. It can come down to 0, which is the seroreversion, which is also fantastic. But yet there are some people who just cannot serorevert. When I say serorevert, they cannot. I mean, they will remain in that level. These are serofast individuals. And you should know that, of course, not everybody, but you should know that occasionally you can come across a situation where something like that, once it comes to your attention as a scientist, you should know that, oh, there are certain people who are like that. You always show negative. The treatment has been, they have gone through the treatment, all the clinical signs and symptoms have all disappeared, yet the test is showing positive. Of course, not the treponema antibodies type. We are talking about the non-treponema ones, which you expect it to go down. It doesn't come down. Either it comes down small and doesn't come down again, or it doesn't even come down at all. Wherever you reach, it will remain there. These are serofast individuals, and it is important that we know about them. Okay. I hope you've understood it. So serofast refers to a state where non-treponema antibodies, of course, you're talking about the IPR and VDR, remain elevated after treatment, showing an insufficient decrease, because remember you said that you should show significant decrease after treatment. Here they are showing insufficient decrease, and the titers will remain high. In certain persons, the decrease in non-treponema antibody titers is less than 4-fold serological titer decline, and even after 12 months, there is no such decline. A serofast state is where titers cannot seroconvert or serorevert to the non-reactive result. This is the same thing that I've tried to explain. All right. So I think the other day somebody said that if you listen to the audios, you get an understanding better than the slides, because the slides, what is in there, I think the explanation usually goes beyond what is captured on the slide. Let's look at some other terminologies associated with the serodiagnosis. All right, and here you're talking about titer. Titer, and in our discussion, we are going to talk about how to determine titers. All right, and you can't talk about titers without talking about serial dilutions. So we talk about serial dilutions. So as you dilute the specimen serially, you see, the more you dilute, the concentration of the substance in the sample, what will happen to it? You do a serial dilutions, you move from one level to the other, and you are diluting serially. As you move along, the concentration of the distance, is it becoming high or low?
Grandpa, low.
Low.
It becomes low. It becomes low. The concentration becomes low. So at a certain point, you of the dilution trail, at a certain point, the test becomes negative, because it has been diluted to the point that probably I mean the concentration has become below detectable level. The last point, which will give you a positive result, after which the rest become negative. That last point, that is your highest dilution. That's what we call a titer. So a titer is the highest dilution of a serum sample that still produces a positive or reactive result. So if you do a dilution A, B, and I'll take you through all that one. Say 1, 2, 3, 4, 5, 6. If the first one was positive, second one positive, third one positive, fourth one positive, fifth one negative. So it means that the fourth one is the highest dilution that gives you a positive result. So the fifth one, whatever dilution in there is your titer. As simple as that. Very, very simple. Very, very, very simple. Or the last dilution that shows a positive reaction against a specific antigen. So specifically, the results are reported in one in so depending on the dilutions that you're making. So depends on the infectious agent that you're dealing with. For example, if you're dealing with the Salmonella typhi group, which you do the you use the VIDA test. Remember, people talk about WIDA, W-I-D-A-L. Please, it is spelled W-I-D-A-L, but the pronunciation is VIDA, never WIDA. Please, even though that's also not a topic for discussion. When you do the VIDA, the diagnostic titer, the titer above which results can be said to be positive or negative, varies depending on the infectious agent that you're dealing with. So the diagnostic titer for salmonella, and for that matter, typhoid, will be completely different from syphilis. It will be different from strep, the strep group A. For strep group A, what serological test do you do? Who can tell me? If you tell me, I'll give you some 10 marks. The serological test that is used for diagnosis of strep group A. Have you heard about ASO test before? ASO, anti-streptolizin O. So I've always said that, you see, everybody, we are all developing in our knowledge levels. We're doing, after our first degrees, we're doing masters, we are doing the MLSDs. But you see, we are unable to do something extra than what we are doing in our basic labs. Okay, because we learn so much and we don't do much to match up with the level of knowledge. So if a doctor requests for ASO, I'm sure you comb the whole of Ghana and no lab will do it. But these are simple tests that must be that. You know, the strep group group A, which is strep pyogenes, they cause what we call strep throat. They cause tonsillitis. Sometimes doctors they can't even wait for the culture to come, just as we have with the VIDA. They can't wait for the culture to come. So you do the ASO. If you do the ASO, anti-streptolizin O, the strep group will produce streptolizins, some antibodies. The ASO, once you do the serological test, ASO level, once you move to a titer of 1/1 in 200, it is diagnostic. Okay, so you must know what infectious agent you are dealing with, because every infectious agent has its diagnostic titer. All right. So, but when it comes to VIDA, for example, so, titers usually should go beyond the 1 in 160. I see people do a titer of 1 in 20 and a report positive. It means we don't know what we are talking about. So you must know which titer you are dealing with. So which organism you are dealing with. If you are dealing with, let's say, the ASOs, anti-streptolizin O, for the strep, your titer level should be in the range of, let's say, 200. So if it's in the range of 200, then you must also design a dilution trail or serial dilution that will capture 200. Because if you do a dilution from, let's say, 1 in 2, and then the next level will say 1 in 4, is that not it? Yes, help me. 1 in 2, 1 in 4, yes. Hello, I'm with you. If you are doing dilutions 1 in 2, 1 in 4, the next level will be what?
1 in 8.
1 in 8. Then from 1 in 8, go to what?
1 in 16.
From 1 in 8,
1 in 16. 1 in 16.
1 in 16, you go to what? 1 in
132.
1 in 30.
You see that you are doubling 1 in 2, 1 in 4, 1 in 8, 1 in 16, 1 in 32, 1 in 64, 1 in 128. You are doubling it. So you call it doubling serial dilution. Doubling serial dilution. If you are dealing with, let's say, ASO, and if you don't understand the concept, you will do 1 in 2, 1 in 4, 1 in, and then Where are you going to get 300 in that dilution tray? How are you going to get 300? You don't get it because it's 1 in 2, 1 in 2, 1 in 4, 1 in 8, 1 in 16, 32, 64, 128. From 122 you go to what? 56 and so forth. How are you going to get the 300 column? How are you going to get it? You don't get it. So you must design it in a way that you are going to capture 300. So you may design y in 10. Then I do doubling dilution, and I'll take you through all that one when we get there. So it means that you've gotten y in 10. But the next level, y in 2. So what is that? If I did an initial y in 10, and the next step I did y in 2, what will be after that? Appreciate it. All that I'm saying is that when it's y in 200, sometimes you can do something like less than y in 40. Less than y in 40 is actually reported in VIDA testing. VIDA testing because you see the test, you want to show that the patient has typhoid. And to have typhoid, your titer should be in the range of at least baseline should be 1 in 80. So if you are starting with y in 40, you don't need to start from y in 10 or y in 20 or even if y in 20 is positive, it doesn't mean anything. Okay, so why are you wasting your time with y in 20? Because the titer which is significant to you is from 1 in 80 going. So if it's 1 in 80 going, which is significant for you, then it means that you have no business working in y in 20. So the best you can even do, okay, let me do y in 40. If you do y in 40 and it is negative, what it means is that your titer is less than y in 40. So you can, that one is permissible to write less than y in 40. Okay, if it's less than 40, if it's less than y in 40, you don't need to move on because it is of no relevance. Clinically, it is of no relevance. So you don't have to waste your reagents. All right, so it is permissible to do that. Or VIDA, anything more than y in 160, for example, is considered to be significant, very, very significant. And you have done the test and you have gotten to y in 256. If we've gotten to y in 256 and it's still positive, it means that you must go on. Okay, but whether it is y in 256 or even if it's more than y in 256, it doesn't change the fact that it is positive. So you may end there because if you don't use your clinical judgment or scientific judgment, you do one case and then you spoil all your reagents. You waste all your reagents. So you must know what you are actually up to and then know how to deal with it. So if I've gotten to y in 256, and by definition of titer, I should do it to a point where the result now becomes negative. If the result becomes negative, then the result is the one preceding the one which became positive. I hope I'm not confusing you. If I'm doing it from 1 to 2 to 3, 4, 5, 6, 7, 8, 9. If 9 is positive, I should do the 10. If the 10 becomes negative, then I can say that my report is the number 9. But if my 9 is positive and I haven't done the 10, I can only say that it's greater than the 9. I hope that point is clear. If I do to 1 to 2 to 3, 4, 5, 6, 7, 8, 9, and the 9 is positive. If I don't do 10, I only know that my 9 is my titer. Because the titer is the highest dilution to give you a last positive result. So if I do the 9, it is positive, I must do the 10. If my 10 becomes negative, then I can say, oh, now my 9 is my last point. And so my 9 becomes my titer. So What I'm saying that it's permissible to do greater than or less than in the titer determination. However, there's what we call endpoint titer. Endpoint is that you must actually get to a last point. Why? So in the diagnosis of syphilis, you are not determining antibody just like that. You are determining the endpoint titer. Endpoint because we said that at the end of the day, if, for example, if you say that it's greater than 256, okay, and you, after a treatment, you want to determine whether there has been serological cure, and for that matter, there should be a reduction in the titer. Since you say it is greater than 256, how will you know where you were coming from? How will you know? So that you must get to the last end, and then so that from next time, if you're doing a monitoring, or if you are monitoring the treatment, you will know that, oh, the last time it was 1 in 256. Now it has come to 1 in 128. Therefore, the patient is recovering. But if you say greater than 256, and we are now in 128, how will you know that there has been that significant change? So, as far as syphilis is concerned, you do what you call endpoint titer. Endpoint titer means that get you to the last point. You don't want greater than or less than anything. Get to the last point and give us the specific results. Please, ladies and gentlemen, are you following me? And do you understand?
Yes, Grandpa.
Okay. So you must do an endpoint titer as far as syphilis is concerned, so that you'll be able to monitor the progress of the treatment. Good. Now, more terminologies associated with the serodiagnosis. It is becoming important to understand agglutination and flocculation, because we say that once we are doing VDRL or the non-toponomy test, it is based on flocculation. People confuse flocculation with agglutination. At a point, they appear to be the same, but they are not. Okay, so I'm sure you are very comfortable with agglutination. You can have antigen-antibody reacting, and where cells are involved, they clamp, and then you become visible. That's agglutination. Here, you are talking about antigen-antibody reaction. And you know that in antigen-antibody reaction, you only have the antigen epitopes, you know, the epitopes of the antigen. And they have to fix with the arms of the antibodies. You know that if you have, let's say, IgG, okay, it's a monomer, and it has 2 arms. It's like a Y. You know this from your basic biochemistry. Okay, it's a Y-shaped. Okay, so you have the heavy chains and the light chains. The light chains form the Y, the arms of the Y. And so if you have an antigen and an antibody, the Y, the points of the Y, they are, even though it's 1, okay, it's a monomer, it's 1. How many particles can it take, or how many antigens can it take? If you have 1 IgG, how many what do you call it, antigens can it take at a time?
Grandpa, 2.
2. So if you have IgM, how many particles will it take? If you have an IgM, how many particles will it take?
4.
GM is a pentamer, or?
Yes, it's a pentamer. That's good. So now that's very good. So it's a pentamer. So how many particles will it take? Antigens.
I take 5.
It will take 10. It will take 10. You see, and that's how come if you have an IgM and IgG reaction, IgM will give you bigger clumps, and then IgG will give you some 5 clumps. Because IgM is a pentamer, and you know for each one immunoglobulin, it's a Y shifting, and it is this 5 of these Ys which is coming up together to give you 1 IgM, and for each one Y, it has 2 arms, and those 2 arms, each of the light chains, can pick up the epitopes will react to the epitopes of an antigen, and therefore can pick up two antigens at the same time. And therefore, once you convert that one to IgM, IgM should be able to take up 10 antigens at the same time. Okay, so in agglutination, there is that specificity, antigen antibody, and they are reacting using the epitopes of the antigens, and which are fixing into the what do you call it? The points on the specific points on the immunoglobulin, and for that matter, yes, the antibodies. That is the element of specificity. So they are very specific, and so that once they come in, because the antigen antibody, the complex that they give you is compact. However, when it comes to flocculation, remember that we said that with the non-treponemal antibodies, they are reacting with all kinds of things. Do you think it is an antigen antibody reaction the way that we did with agglutination? And agglutination, specifically antigen antibody reaction, and they are involving the epitopes of the antigen specific for the specific antibodies. But when it comes to flocculation, it is not specifically antigen antibody. Anything that has the potential of bringing the thing together is still a reaction. So you see that they also form aggregates or clumps. So please, I hope I'm not confusing you. With the agglutination, you still get clumps. Flocculation, you still call clumps, but it is not as a result of antigen antibody complex the way we want it. And therefore, there's that kind of losing. Is like, if even there are clumps, there's an element of lose. Okay, and so because they are loose, they are easily able to precipitate out of a solution. So that's the element of flocculation. And this is what happens once we are dealing with the non-treponemal antibodies, because they are non-specific and they are not typical antigen antibody complex situation that we deal with. And so once we are dealing, even though they form clumps, yes, they form clumps, but the clumps that is formed in agglutination, they are called aggregates or agglutinates. The clumps that are formed in flocculation, they are called floccles. And I want you to understand some of this so that you go beyond the ordinary science level knowledge. That's what I want you to do. That you have completed your basic science or whatever, or your first degree or whatever. You are doing something which is beyond that, and therefore you should get proper science understanding of some of these things. All that I'm saying is that agglutination and flocculation, technically they seem to be the same because they are all clumps. But the clumps in agglutination is more compact because it involves antigen antibody reaction where there's that element of specificity. In the flocculation, there are still clumps, but they are not proper antigen antibody. They could be just some any mechanism that is bringing some certain things together. All right, so they also form clumps, but there's an element of looseness in it, and they are called floccles. The other one is aggregates. But when it comes to the level of this, and they are all clumps. But the difference.
Hello, Grandpa.
Yes, sir.
Yeah, please.
Please, I can't hear you. Hello, no. I thought Nuhu was talking. It's gone off. Oh, so
No, the network is bad.
Oh, sorry. Moses, are you talking? Do you want to ask a question?
No, sir. I was saying the network has been good today.
The network is bad. Sorry. But all that I'm trying to explain the difference between agglutination and flocculation. I'm just saying that when it comes to the non-treponemal testing with respect to VDRL and then RPR, they are based on flocculation principle, right? However, flocculation, agglutination, they are all clumps. But as scientists, you should appreciate the difference between agglutination and flocculation, where agglutination involves proper antigen-antibody interactions, where epitopes and the antibodies are combined, and there's that element of specificity. Okay, all right. So the level of agglutination or flocculation varies depending on the relative concentrations of antigen antibody. We are coming to a level of the zone of equivalence. So we know that whether it's antigen or antibody, there's some element of, whether it's agglutination or flocculation, there's element of some interaction of antigen and antibodies. Now, the extent of the agglutination or flocculation will depend on the concentrations of the antigens and antibodies. I hope that point too is very clear. All right. So I've already mentioned the proton effect. The proton effect is also called the hook effect. The hook, these are terminologies, and you must understand them and be able to apply them in your practice. Okay. The proton effect is the same thing as the hook effect. Whether in agglutination or flocculation assays, the zone of equivalence, the zone of equivalence where the concentration of antigens and antibodies are very much like optimal. I mean, they are of reasonable proportions. That will give you good agglutination or good flocculation. So that is zone of equivalence. The quantities of antigens and the quantities of antibodies are reasonably in their right proportions, and they'll give you effective agglutination or flocculation as the case may be. Now, if there is excess antibodies in the serum or antigens in the assay, they can interfere with the development of the clumps, leading to false negative results. And this phenomenon is called proton or hook effect. I think I've explained this already. Now the slide has come. Okay. So when you have too much of the antibodies over and above the antigens, you end up getting no reaction. So you get false negative results. And once that happens, it's called proton. Now, how do you deal with proton? Diluting serum can remove the proton. Okay. We say that there are too many of the antibodies in the sample. And once you do the sample raw, all right, then the results can become negative just because the antibodies in the sample that you took are so much they have overwhelmed the antigens. And at the end of the day, there's no reaction. So you report as negative. That this negative is a false negative. And it is due to the overwhelm. What you have to do is to dilute the specimen. Once you do the dilute the specimen, what are you doing? You're reducing the quantity or the level or the concentration of the antibodies, because we say that the antibodies are too much. So if you dilute it, you reduce the antibody to a level that can match the antigen. Remember, the antigens is your reagent. And so if it's one drop that you took, the quantity will be the same. But the antibodies are coming from the serum, and you say they are too much. So if they are too much, just dilute it. So if you do dilute the specimen, the sample, the result will now become positive. Okay. So that is all. That is the way to deal with proton effect. Is there any question, anyone misunderstanding anywhere? If you are suspecting a proton effect, dilute the sample, and then the test will now become positive. Now, if you use the undiluted specimen, the undiluted specimen is called neat sample. So if you have serum or plasma or blood or anything, and you are using even urine, and you are using it raw from its raw state, it is called neat sample, N-E-A-T, neat sample. The undiluted sample is neat. All right. So if you have a neat sample of serum or plasma, and you suspect a proton effect, all you got to do is to dilute it. Sometimes, even if you dilute it, you still get negative. But as the dilution increases, so you can have a situation where you may get 1 in 2 dilution, it's still negative. You do 1 in 4 dilution, it's still negative. You do 1 in 8 dilution, then begins to become positive. What it means is that the level of the antibodies in there are just too much. And apart from the antibody, there could also be interference substances. So the antibodies are too much, and other things which are also not even related to that, they are all causing interferences. So as dilution increases, the amount of the antibodies themselves are reducing. And again, the interference substances will also decrease. Okay, and then now you get to the zone of equivalence where the samples that will now give you a positive result. So as to what level to dilute, sometimes you may give the trial and error, but that is for if you are doing some research. But for routine tests, you don't normally do the prozone this thing. But what I'm saying is that as scientists, you must know these things happen. Okay, you must know these things happen, and once in a while, you may want to challenge the status quo and see this case, which is always negative. I'm suspecting that it's positive. Will it be a prozone effect? Why not? Then you give it a try. You just do some dilution, and then so as you dilute the sample, rather the test become positive. Then it means that it was actually due to a prozone effect. All right. So then there is this biological false positives. That one is different from the prozone effect. The prozone effect will give a false negative. Prozone effect will give you a false negative. Biological false positive will, of course, give you a false positive. That's we are dealing with non-treponema tests. How about the patient have, let's say, HIV, have leprosy, malaria, but got vaccination some few weeks ago. All those things can give you a positive reaction. Meanwhile, they have nothing to do with treponema. So you call them biologic false positive, BFPs. And this is where if you do the treponema one, because these ones are specifically for the non-treponema test. Okay, if you do the treponema one, then because that one is specific, then it will become negative. Okay, because if it is due to a BFP, the biological false positive, due to some HIV or something, and the patient tests positive. If you do the TP, the treponema pallidum itself, which is specific, and it becomes positive, then become negative, then it tells you that the positivity that you got from the non-treponema one is a biological false positive, BFP. So right. So we have BFP reactors. BFP reactors, that is the individual in whom you found a false positive. That individual now becomes a BFP reactor. That's all. So the test itself showed positive. The non-treponema test from a particular sample showed positive. We did the treponema test, it became negative. How will you explain the first positive? The first positive is a biological false positive. Straight away. The individual who showed the biological false positive is supposed to be called a BFP reactor. That's all. That's all. These are terminologies that I want you to be familiar with. So anytime you meet anywhere or you are discussing anywhere, you are not confused. Okay. Good. Now, let's try to now zoom into the tests themselves, the laboratory testing. said that syphilis screening tests use the non-treponema antigens, which said they are called lipoida, and it said that OID as a suffix means like, and then it's just the adjective, so lipoida, lipid, okay, and then just add the OID. So lipoida means it is like a lipid. And these are made up of cardiolipin, which is the diphosphatidylglycerol. That's the chemical name, but just take it as cardiolipin. And then lecithin and cholesterol. These are all related with lipids. Okay, so they are all lipoidal. And that's what I was trying to explain earlier. So they are all lipoidal antigens. And since the test is going to use these antigens, then the antibodies reacting with these antigens become anti-lipoidal, like I tried to explain earlier. Now, this, especially the lecithin and then cardiolipin, they are usually obtained from beef heart. You know, cardiac is heart. So beef, of course, you know where it is coming from. So it is easy to prepare the reagents for the VDRL from lipid heart. Of course, I'm not saying you, but that's the source. As for cholesterol, it can be gotten from anywhere that's added. Okay. Now, this is the reagent that is used for the RPR, which is the rapid plasma reagent, as well as the VDRL. Okay. Now, of course, the most commonly used non-treponema, non-specific tests are the VDRL and the RPR, which detect anti-cardiolipin antibodies. I've said this already, and I'm saying that when we're dealing with the reagent, cardiolipin, lecithin, and cholesterol, the largest amount proportion is coming from cardiolipin. So if you come across anti-cardiolipin, you say talking about the non-treponema test. Again, if you are talking about, if you come across anti-lipoidal, it is still about the non-treponema test. All right. So, right. The VDR test, of course, named after a laboratory that developed it. And of course, it's a non-treponema serological screening for syphilis, also used to assess response to treatment to detect CNS involvement. Remember, we said that syphilis, the last stage of the infection is the tertiary stage. And at that stage, there can be CNS involvement. That is, it can affect the central nervous system to cause neurosyphilis. Now, so if you have neurosyphilis and want to diagnose, what specimen are you going to take? The suspected case of neurosyphilis. What specimen will you, are you expecting?
The cerebrospinal fluid.
That's it. CSF. You expect CSF. As you move along, to be interesting, it can come to you sometimes. You'll be in the lab, and then a doctor will bring CSF and say you want to do VDRL on it. I'm sure some of you will be using the strip, and that would be very, very unfortunate. Right. So the good thing is that with the CSF, you do the VDRL if you have it. You wouldn't do the RPR. Remember, I said that the RPR is a modification of the VDRL. I will explain as we move along. With the CSF, there will be no need to do. Remember, I said that for VDRL, you have to heat inactivate. Do you remember that?
Yes, please.
Yes, you have to heat inactivate to minimize the risk of the interferences. The things that are in CSF, when you are taking CSF and then you're taking the serum, CSF comes nowhere close to the serum. So the things that will cause you force reactions and this thing, are they in the CSF? The things that for which you did the basis for which you did the heat inactivation, the conditions, are they present in the CSF?
No, please, they are not.
No. So it means that if you are to do CSF, you don't do heat inactivation because there's a basis for the heat inactivation. There's a basis for that. And then also let me also add, in fact, I was playing as we move to the proper testing. Anything that you are doing, you must understand the science behind it. That is all. That makes you the scientist. Because if you don't take care, then say, okay, if you are doing VDRL, the sample must be heat inactivated. You also get CSF, and then you are also going to going to put in the water bath for under 30 minutes. For what reason? It means that you don't understand the reason, the science behind the heating of the serum. If you understand it, you see that, oh, the conditions that are in the serum for which you heated, those conditions are inapplicable for the CSF. And for that matter, you don't need to heat. All right. That's just by the way. So the VDR antigen reagent is an ethanolic, which is solution containing all the things that you said already. All right. Okay. So we move on. So coming back, the VDR test require heat treatment of serum sample, which is heat inactivated serum. As the presence of complements in freshly drawn serum makes the test less reactive. I've explained this already. And by the heat inactivation, you are only going to heat the sample. Of course, in this case, you use the water bath. You put the sample in a test tube, you put in the water bath for 30 minutes prior for testing. Now, the heating of plasma at the same temperature, let me do this for you. You see, in trying to compare VDRL and then the RPR, you said that RPR, you can use plasma, okay? Now, with VDRL, we don't use plasma for reasons that I explained, that there are too many things that are causing interactions with the VDRL, okay? So somebody will say, okay, but with the serum you heat it, and then you use it. You heated the serum so that you can inactivate the serum and for that matter, take away a lot of the interferences. So then why don't you do the same for the plasma? Because if you also did the plasma, then of course you're also going to deactivate and then use it. However, in plasma, if you put plasma at 56 degrees for that period, there's going to be fibrin formation. Who can tell me, if you have plasma, how can you convert plasma to serum? Who can tell me?
Akwala be no di jun so bae.
Akwala be no di so bae. I don't know. Gladys. Who are you, man?
Grandpa.
Grandpa,
but you me you more.
Hey, you are this time. Now, do you who follow discussion here?
Grandpa, to be say yeah, to be me follow grandpa.
Hey, awesome. And then say no aboka. Okay. All right. So if you have plasma as a scientist, how will you turn it to serum? Who can tell me? The biochemist. You have plasma. How will you turn it to serum? somebody should try. The chemistry people. You have plasma. How will you convert it to serum? Okay, that's assignment. Go and find out tomorrow when I come. When you come, you come and tell me. Yes, is somebody trying?
I think you reintroduce clotting.
So what will you do?
I think it has to do with calcium by adding calcium.
Calcium chloride. Add
Calcium.
calcium chloride, and then of course, remember thrombin will have been used, so you also add thrombin.
Thrombin, okay.
Okay, so then you remove the fibrin from it. So they call it defibrillation. Yeah, remember we said that when you have the prefix D, it means removal. So if you say defibrillation, so it means you're removing the fibrin from it. And as soon as you remove fibrin from plasma, what have you done? We have taken off all the red cells have been taken off already. Okay, to give you the plasma, because you span it to remove the plasma. So the red cells have taken off. So all you need, because in the clotting, you form fibrin, and the fibrin entangles the red cells to give you the clot. Now the red cells is not available in the plasma, but the fibrin too, once you're able to remove the fibrin, we have brought the whole system back to serum. So please let us try to educate ourselves beyond what you learn from school, because I always say what you learn from school, even if you spend 6 years or 7 years or 8 years, you still will not have learned everything. So when you come back, there should be a lot of self-education. Okay, you have to do a lot of self-learning and make sure that you understand the aspects of everything that you are doing in the lab. Okay, so we are saying instead of now, if you put the plasma in the 37 at 56, instead of removing the fibrin so that you could get serum, rather you are enhancing the formation of fibrin, and therefore it still comes back to the point that you cannot use plasma for VDRL. Okay, right. I've explained this already. VDRS is a flocculation test, and I explained the difference between flocculation and then the agglutination. Okay, they are all clamping. They all involve clamping. Okay, but one is more complex than the other. Then with the VDRL, the test is performed on glass slides and read using light microscope under a ×10 objective lens. So if you ×10 objective lens, what is the magnification required for VDRL examination? I said the test is performed on a glass slide and then read using light microscope on the ×10 objective. So if I ask him a question, what magnification will be required to examine VDRL report or test or slide? What would be the magnification? I hope people are not sleeping. Are you people sleeping? A lot of you are sleeping.
No.
Eh?
No, please.
No, sir.
Is it? So what magnification are you talking about here?
×10.
×10 magnification.
Yes.
It will be ×100. You know why? Why? Why will it be ×100 magnification?
Because 10 of the eyepiece lens and 10 of the objectives, so 10
Eyepiece,
times
the
100.
ocular lens is usually 10 × 10. And so if you are examining this one on that times, it means that the final magnification is ×100. So take note on some of those things. So you use a ×10 objective, and for that matter, a total magnification of ×100 to observe the flocculation in respect to the VDRL. So VDRL, one is microscopic, you need a microscope. And then two, you need to heat your serum, and you can use plasma. These are all some of the challenges associated with the VDRL. Okay. However, it is still the cardiolipin lecithin cholesterol reagent. It is the same thing that is also used for the RPR. Once you come to RPR, you understand where the difference is coming from. So VDRL is microscopic, and then you need a microscope, okay? And then the reagent is the same, cardiolipin lecithin cholesterol. That is why you cannot use CSF using the, for example, the RPR. When it comes to RPR, even if you have it, you can use it for CSF. You can use the strip that people are using for CSF VDRL. Okay. Because it is microscopic. You see that I'm hoping that all of you may have had experience in Coombs test. Do you know the Coombs test? Ladies and gentlemen, do you know the Coombs test?
Yes.
You know that the final reporting examination, you need a microscope. So that any tiny agglutination can be picked up. Now, when it comes to CSF, antibody levels is just because the cells, the lymphocytes which are supposed to be producing your antibodies, they are not present in the CSF. So CSF antibody levels are usually very, very low. Once they are very low, if you do the tests and use the microscope, if it's in a suspected case of neurosyphilis, because you will be using a microscope, the slightest aggregates or the slightest clumps, you'll be able to observe it. Okay, so once it comes to CSF syphilis examination or testing, you need VDRL, and you also will need a microscope. You can use the other things that we're going to talk about for CSF. So take note. I'm sure one day, some of you will be confronted with a CSF sample. A doctor wants you to do VDRL, and you may be found wanting. I'm sure after this course, you'll be able to handle such cases. All right. So we will end soon, and so that I get a feeling that a lot of you are tired and dozing off. All right. So let me end here, and then we will continue tomorrow the rest of the VDRL, and then okay, I think this is the last slide on the VDRL. So then tomorrow, God will do the RPR. So the VDRL tests detects anti-cardiolipin antibodies. We've mentioned this already. And the antibodies involved here include IgG, IgM, and IgA. Remember, IgA is also bivalent. IgM is pentavalent. IgG is it's a monomer or monovalent. Okay. All reactive samples for VDRL should be retested with the treponemal method, such as TPHA. TPHA used to be the commonest, and even now, some doctors will still request for TPHA. All right, but now nobody is using TPHA. So in the course of the discussion, we will also show you what to use in place of the TPHA. If a doctor requests for TPHA, what to do and what to use. All right, but TPHA is treponemal palladium heme agglutination assay, and start the TPHA. That is also a part of the treponemal tests. And treponemal tests are specific, as you know. False positive results have been reported in diseases such as, we've mentioned this already, that is the false biological false positives. We mentioned malaria in the previous slide, but here you're also including infectious mononucleosis, viral pneumonia, toxoplasmosis, pregnancy, and autoimmune diseases. So if anybody has any of these ones, it could give you false positive results for VDRL. So ladies and gentlemen, we end here for today because you are too tired, and I just want to make sure that whatever we have taken you through, you'll be able to understand them and then be able to practice them. Okay, so that those that you are already doing wrongly, you correct them. Those that you are not even able to do, but after the course, you'll be able to do some of them. For example, how to get VDRL and RPR. All right, all those things will give you information about them so that you can also introduce them in your labs. Thank you. And if there are any questions, please bring them. Otherwise, we call it a day.
Okay, Grandpa.
Yes, sir.
So this Moses, I don't have a question, but today's network has been up and down, and some parts may not have gotten some of. We might have lost some of the time.
Okay.
In conversation. So I would like to plead with the one who is doing the recording, the facilitator.
Okay.
The recordings can be placed on the platform, not the platform. I mean, site.
Okay.
Where
I think the challenge is that, you see, this is a paid course. If you don't put some restrictions and then the recordings and everything goes out there, then what is the need? I think that is the essence. That's the essence. That is why we are unable to put some of those things on the platforms. And even the links, I'm sure some people are sharing the links with some colleagues, and which is also not too good. If it was a free course, fine. That one is a free platform.
My network is off again.
It's a paid for course. There must be some restrictions on. You don't think so?
Hello.
Hello. I'm saying that we are also trying to protect those of you who have paid. Okay.
Hello, Grandpa.
Yes, dear.
Hello.
Yes, dear.
Grandpa, I think what he's saying, I think is somehow is good, because some of us, anytime we are having lectures, we are at work. As I'm talking, I came afternoon and I'm still around. So anytime the lecture is going on, I don't benefit much.
You were there
like
when
my
all of us
attention
were
is
voting on. You see, I said that I'm available anytime, any day. So all of us, we try to vote on the date, sorry, on the days and the times. We agreed to all these things. So if now it becomes a challenge, well, I'm still amenable. We can still decide on to change the timing and also the days. I'm very, very, very flexible. I'm very flexible. So if both the days and times are not convenient for most of you, please let us all discuss and then come to, I am free. I'm totally free. Okay. So I'll just do what to please majority of you. Of course, it cannot be everybody, but majority of you should be able to give us a good time in the day.
okay.
Is that all right?
Yes, sir, Grandpa.
Okay. But by the way, if I want to know how you if I have to ask you, how are you getting it? I mean, is it below your expectation so far? How far have you gone? Below your expectation, or
Grandpa,
it's far, or above?
It's far exceeding what we expected. Actually, it's really educative. Really.
That's from your end. If you say are you talking for everybody?
I'm talking for myself.
So let me get a feedback, because I want it to benefit you. Okay. At the end of the day, you should be able to know that you have learned something. All right, thank you. So we'll move on tomorrow, God willing, same time. Please, I'm still flexible. Let me be very honest with you. I'm still flexible. if majority of you want us to change the time, please let me know. I will adjust accordingly. Okay. So, course rep and then the deputy, you can discuss this thing behind closed doors and then get me the feedback. Okay. Good night.
Good night.
Good night, Grandpa.